Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a very interesting case of a patient who attended with a Keratosis Obturans, and I would classify as a grade 3. That's in their right ear, so do stay tuned. Just commencing with this, their left ear. So in this left ear, they do have a dead skin plug, but we wouldn't classify this as Keratosis Obturans because they don't have the hallmark symptom of Keratosis Obturans, which is otalgia, ear pain. In order for you to be diagnosed with Keratosis Obturans, you must be presenting with otalgia, ear pain. Now, if left untouched, this left skin plug could eventually form into a Keratosis Obturans, causing the patient pain. But as it presently stands, we would just classify this as occluding dead skin. So it may look like earwax, but once you're in there and you're making contact with this dead skin plug, you can almost instantly tell the difference between earwax and dead skin. Dead skin can be quite dense and sticky, can be quite glossy, it could be stretchy. A good way of describing a dead skin plug, you can compare it almost to chewing gum or dried up glue. It's got this elastic, stretchy property. Almost here, I'm really having to tug away at this and it's almost stretching and elongating. So we're making good progress. They have got a narrow entrance in both ears, particularly their right side, which made the removal of the Keratosis Obturans even more difficult because with it being a grade 3 Keratosis Obturans, they had a really widened osseous portion of the ear canal, the bony part, whereas the entrance is really, really tiny and narrow. I would say this ear was slightly wide at the entrance, but nonetheless still quite narrow. And as you can see, they've got a lot of hairs at the entrance. Now, this patient is of Asian descent, and it's probably just an anecdotal observation of mine, but I do find that patients of Asian descent do have more cilia, so hairs at the entrance of the ears. I know I do. My hairs are quite hairy at the entrance, and also males. So as men get older, you tend to have a build-up, growth of more hairs, both at the entrance of the ears and up your nasal passages. I think the reason for that is men have a build-up of testosterone, which can then lead to hair growth. But the hairs, the follicles at the entrance of the nose and the ears, they almost desensitize to testosterone until later on in life. And when they become sensitive to testosterone, it then leads to additional hair growth in these areas and regions. So we're able to visualize the patient's eardrum there at 3 o'clock. And as is normally the case with dead skin, we're still trying to peel this away because it is quite sticky. So that blue tinge on the right side of the screen, that's the patient's, we'll classify that as a posterior inferior portion of the eardrum. So in the case of the left ear, we'll could label that as the southeast region. So even at this stage, the patient could hear significantly better, but of course we want to remove this remaining skin. I'm trying to detach it from the roof of the ear canal there. And because of the sticky consistency, it can often block the suction probe. So quite often you can come out of the ear and using a cleaning rod or extruder, push it through the suction probe to unblock it. You can see that back part of the skin plug is still attached to the eardrum, so we're just trying to remove this gently. Instead of just pulling it laterally, so getting a suction and pulling it straight away, your little wriggle movements like that, and you can just help to detach it. Of course, a bit of oil, so we used a bit of oil as well before, just to get in behind that skin plug in the eardrum to lubricate it. So I've brought it away from the patient's eardrum. It's now just a case of extracting it from the entrance of the ear, which is a bit more difficult than it would appear because of, as I said, it's narrow, so I just have to wriggle this through. It's just detached from the main plug, that piece I removed there. I am taking short intervals with my narration here, so just still got a bit of a sore throat. So I'm just pausing it, having a little break, and then going back to the narration. There's another big plug there. And slowly but surely we're clearing this ear out. It's just the last piece. So for quite a small ear, it did pack a lot of dead skin. That's another an obvious difference between earwax and dead skin. When you've got dead skin plugs in the ear, you can really compress a hell of a lot of dead skin in there, as opposed to earwax. I think with earwax, there's a certain amount of wax that is possible to build up in an ear. With dead skin, because it can squash and fold upon itself, you can really extract a tremendous amount of dead skin, a lot more than you would envisage. So this is their right ear. And when the patient attended, I treated the right ear first, but for the purpose of this video, I wanted to show you the other way around so we can almost focus now just on the right side. So this patient 4 years ago had a blocked right ear. They went to visit another local specialist who wasn't able to remove it, so they were referred to ENT, and they had a couple of attempts, a couple of appointments there, and eventually they managed to remove this. Now, ENT did advise the patient to use drops on a regular basis to kind of soften this plug, but the patient hadn't been doing that. And then I saw this patient prior to me going away on my holidays. They woke up one morning and it was quite painful and they were really struggling to hear. They weren't aware that they had Keratosis Obturans, so it was only once I started performing the procedure, as soon as that first contact with the plug, I immediately recognised it was Keratosis Obturans. And so at the end of the appointment, sat down the patient, just discussed the condition, which I'll explain in a moment to everyone, and the appropriate aftercare with this, because this patient will need regular debridement of their right ear. So the entrance is quite narrow, so I'm using the endoscope to stretch it wide open, and that did actually make the procedure a lot more difficult, because gaining access, and also with Keratosis Obturans, you need the manoeuvrability with the instrument. So when you've got a narrow entrance, it can kind of constrict you somewhat. And as I mentioned, this consistency, it's almost like chewing gum or dry glue. Dry glue is probably a better analogy, actually. So what is Keratosis Obturans? Now, it's a build-up, a very slow accumulation build-up of dead skin cells in the ear. And typically, when the skin cells in your ear die and shed, they separate into individual scales, if you like. So if you think about the individual skin cells being like fish scales, whilst they are alive and lining the ear canal, they're all interconnected. But as the skin cells die and goes through a process called cornification, these individual skin cells, they separate and should flake off individually as it reaches the entrance. So this skin, it starts migrating from the eardrum, the outermost layer of the eardrum, which is made up of the epidermis layer of skin, which is the skin that lines the outer portion of the ear canal. The shedding process starts from the center of the eardrum. So the dead skin on the eardrum, as it dies and sheds, it radially moves outwards from the center of the eardrum, almost like the ripples in a pond when you drop a pebble. So imagine those ripples being dead skin, and then the skin, as it comes off the eardrum, it then slowly migrates from the deepest part of the ear canal, slowly but surely out of the ear. The rate of, we call it epithelial migration, that process, it's between 1.5 millimeters to 3 millimeters a month. There's obviously individual differences there, not only between ears, but individual people. But with the Keratosis Obturans, the skin, it tends to not separate the individual skin cells. So although the skin's died and shedded, it's not individually flaking quite often with Keratosis Obturans. So they form what we call a lamellar structure. So lamellar structure, it's almost like an onion-like structure. So imagine you've got these sheets of dead skin lining the ear canal, and as they die, the sheets are still intact. All of the skin cells, individual skin cells, are dead, and they've separated from the canal wall. They've not separated from one another. and then you get another layer of a sheet of dead skin, and then another layer of sheet of dead skin, and they overlap and interconnect, and it forms like an onion-like structure. And then this onion-like structure forms into a plug, and this plug gets bigger and bigger and bigger and bigger. Also, typically with Keratosis Obturans, the skin migration is abnormal. Instead of the skin migrating from the deepest region of the ear canal to the entrance, so in a lateral plane, with Keratosis Obturans, quite often the skin, as it sheds and migrates, it migrates inwards in towards the centre of the ear canal, so it doesn't fully escape, and then it coils these onion-like sheets of dead skin coil over each other, forming a plug and a ball, a plug which just gets bigger and bigger. It's almost like a rubber ball. Now, the incidence rate of Keratosis Obturans, the data suggests 4 to 5 per cases that attend an ENT and audiology clinic. Now, I'll come back to it in a moment. Now, here you can see granulation tissue. So this bleeding is not due to myself making contact with the canal wall and causing trauma. Instead, this is one of the hallmarks of a grade 3 Keratosis Obturans, and I will go through the grading system in a moment or a bit later even, but you get the formation of granulation tissue. So when you then remove the plug of skin, this granulation tissue has its own blood vessels. They are ruptured, and you get what we call contact bleeding. So straight away, I know this is a grade 3 because that's you wouldn't classify a grade 1 or grade 2 Keratosis Obturans in the presence of granulation tissue. So I'm just using a Jobson horn. I'm also using the ear pick here, but it's just too stretchy and elastic. And a bit later, I'm going to use the forceps. The forceps did help at times, but other times it just separated bits of this skin plug. Instead of extracting it, it just plucked away little sections of it. But you saw there, the ear pick was quite handy because it did bring the plug forwards. So I'm just alternating between the instruments. I've seen a little gap here where I can glide the ear correct in between the epidermis skin plug and the canal wall, and I'm rotating it and bringing it forwards. It's really quite dense and thick and stubborn material. So with Keratosis Obturans, 50% of cases are in both ears. It's not always bilateral. So in this case, for example, this patient's only got it in one ear. In terms of age, it's most common amongst patients who are below the age of 40, the primary age between 20 and 40 years of age. And also, females are more prone to having Keratosis Obturans than males. And anecdotally, I can kind of somewhat confirm that as well through my own experience. I don't know the exact ratio, but certainly I do see more females with Keratosis Obturans than males. So the symptoms of Keratosis Obturans, the primary one is acute pain, so quite sharp, sudden, acute pain. It's rather than a dull pain, so rather than a dull ache, it can be extremely excruciatingly painful for a patient when they present with Keratosis Obturans. So for that reason, sometimes it's not uncommon for Keratosis Obturans to be removed either under local or general anaesthetic. There are cases where that is necessary. Of course, when you've got Keratosis Obturans, you're going to have what we call a conductive loss. So what we mean by conductive loss, the organ of hearing itself, the cochlea, is relatively unaffected, but the sound can't reach the cochlea due to the obstruction in the ear canal. So when the sound can't travel through the ear canal or the eardrum to the cochlea in the inner ear, we call that a conductive loss. And in really severe cases, patients who present with Keratosis Obturans can suffer from facial palsy because it can affect the facial nerve if it's growing medially into the middle ear. Again, in extreme cases, it can cause damage to the organ of hearing. I've never come across a case that severe before, mind you. And it can also cause a dehiscence of a thin sheet of bone called the tegmen tympani, and that bone acts like a roof separating the middle ear, which is the cavity behind the eardrum, and the skull base. So when we mean by dehiscence, it can kind of cause damage to the bone. It can cause that thin plate of bone, the tegmen tympani, to no longer be present. So rather than eroding it, it can just apply so much pressure with that bone undergoes a process called bony resorption, and I'm going to talk about that a bit more in a moment actually. Another hallmark of Keratosis Obturans is a thickened eardrum, and that could be due to hyperkeratosis, which is quite common in cases of Keratosis Obturans. Hyperkeratosis is just a thicker layer of epidermis due to more keratin. So the epidermis layer of skin that lines lines most of your body, or lines all the skin in the body, the outer layer of skin, apart from the mucosal layer. It's got 5 layers, and the basal layer is where the individual skin cells can reproduce themselves, and the parent cell is then pushed upwards by the daughter cell until eventually it's the most outwards facing layer of that epidermis layer of skin. And as that parent layer is being pushed further and further away to the surface of the epidermis, it undergoes a process called cornification, and that's when that individual skin cell starts slowly but surely producing keratin. So keratin is a protein, and the outermost layer of skin, as it's going through that cornification process, all the functionality of that skin cell dies. So there's no more organelles, which give the skin cell its almost primitive life. All the intracellular fluid is no longer present, and instead that skin cell is just replaced and filled up with keratin. So keratin is the same protein you find on your fingernail and your hair strand. It has got some very useful benefits, actually. Keratin helps to reflect harmful UV sun rays. In addition, it's hydrophobic, so it helps to repel water. Water is bad for the ear, so we don't want water in the ear because it can then lead to an ear infection. So some patients with Keratosis Obturans, they have high levels of keratin, which then causes a thickness of the eardrum as well, because remember the outer layer of the eardrum is an epidermis layer of skin. Sometimes patients can develop Keratosis Obturans because they just have a higher volume of skin cells in the ear, higher than average. And if you've got a higher than average number of skin cells in the ear, when they die, they can eventually then form into a keratin plug. So your ear just can't basically shift these dead skin cells at a quick enough rate because you just have too many to begin with. So the grading system of Keratosis Obturans, you get a grade 1 to a grade 4. So grade 1 is when a patient attends with mild pain, but upon removal of the Keratosis Obturans, you don't really see a noticeable expansion of the ear canal. So a widening of the ear canal. A grade 2 is when a patient attends with moderate to severe pain, and upon removal of the skin plug, you can see a mild expansion, widening of the ear canal. Now a grade 3, which is what this patient presents with, is again they've got moderate to severe pain. They've got moderate expansion of the ear canal, which this is what this patient has, and you can't see it at the moment, but you will do when I remove this plug. And importantly, the key distinction between a grade 2 and grade 3 is that they have granulation tissue present at the juncture of the ear, which we call the osseo-cartilaginous portion. So that's where the cartilage portion of the ear canal meets the bony part of the ear canal. So you can subdivide your ear canal into thirds. The outer third is made up of cartilage, the inner 2/3 is made up of bone, and where that cartilage and bone meet, we call that the osseo-cartilaginous portion or junction, and you get a buildup of granulation tissue there. And a grade 4 is when a patient attends with severe pain and severe expansion of the ear canal, which can extend to the mastoid region and also possibly affect the facial nerve. Now, you will see when I remove this patient is infringing on a grade 4 because they are beginning to develop early signs of an automastoidectomy. So the bone at the rear of the ear canal, so in this case, it's the bone to the left, which is still not visible. That's the mastoid bone, and you can actually feel the mastoid bone if you get your finger and position it behind your ear. There's a flat surface there, we call that the mastoid process, but that's the mastoid bone. And the mastoid bone is a bone, it's porous, it's air-filled, it's It's like a honeycomb structure inside. So that's the back of the ear canal. So when you've got a grade 4 keratosis obturans, the widening of the ear canal can become so severe that the back part of the ear canal merges with the mastoid bone. We call that an automastoidectomy, because there is a surgery called mastoidectomy where the ENT surgeons deliberately drill away the mastoid bone to remove, for example, a cholesteatoma, which is a very severe and serious ear infection. But in this case, there is elements that this posterior bone is merging with the mastoid bone. So you can almost classify as I think I mentioned to the patient they may have a grade 3.2 keratosis obturans, although there's no such thing, but just to let the patient know that they are slowly developing into a grade 4. So it's very important that we keep on top of this moving forwards. Now, what causes this widening of the ear canal? Now, the cause, it can be twofold. It can be due to just the direct pressure of this plug. So when this plug of dead skin grows, there's so much pressure, physical pressure, that it literally just expands the bone. But more often than not, it's due to a process called bony resorption. And bony resorption occurs when, because of the pressure caused by this plug of dead skin, it causes a bit of inflammation to a part of the bone called the periosteum, which supplies, it's a thin sheet that lines the bony part of the ear canal. It supplies all the blood, the nutrients to the bone. And that physical pressure can kind of aggravate this periosteum, cause inflammation, which can then cause dilation of the blood vessels. And that can then activate a cell, a specialized cell sitting on the surface of the bone called osteoclasts. Now, what osteoclasts do, they're involved in the breakdown and dissolving of bony tissue and material and minerals. And then these bony tissue and minerals, they are released back into the bloodstream by the osteoclasts. So other parts of the body can reuse these bony tissue and minerals. And that then leads to a remodeling of the ear. It causes a widening of it. In addition, the reason why people develop granulation tissue in cases of grade 3 and above keratosis obturans is, again, due to the inflammation caused to the periosteum by the skin plug. It causes a process called neovascularization, which is the formation of new blood capillaries. And when you've got inflammation, your body produces inflammatory cells called granulation tissue, and it's essentially connective tissue that has its own blood supplies caused by the formation of those new blood capillaries that I just described by the process of neovascularization. So when you remove a keratosis obturans, you're rupturing that quite often, that granulation tissue, and also those blood capillaries, so you get contact bleeding. In fact, we might have missed it, but I think when I removed, you might have seen a bit of granulation tissue at the entrance of the ear canal, and I suctioned it. So it's almost like it has a fleshy type appearance. So that's that big plug. And another characteristic of keratosis obturans, you would have just seen it there, the peripheral coating of the plug is a silvery white matrix, and that's the most recently shed layer of dead skin. So as the skin layers, you can see it when you've got dead skin on your finger. That's a good example. If it's just freshly dead skin around your fingertips or the bottom of your fingertips or around your nails, that skin is white in appearance, and then eventually, if it doesn't fall off and it remains there, you'll see it change colour. It goes through the oxidation process. It'll turn orange, brown, and almost then black. So keratosis obturans, you just saw it earlier, that main plug, it was enveloped by this silvery white matrix, which is the most recently shedded layer of skin that's enveloped itself and added itself to the skin plug. What makes keratosis obturans also quite difficult to remove, because of that inflammation caused by the pressure of the plug compressing against the canal walls, it can then lead to inflammation, so edema, swelling, laterally, so in front of the skin plug, which then again narrows the space. So this plug that I'm removing, it's probably 5 times the size of the entrance of the ear canal. So if you add inflammation to that, it just narrows the entrance. It makes it more and more difficult to remove. Now, generally speaking, there's 2 types of keratosis obturans. You get inflammatory type, which is caused by underlying inflammation. So again, when you've got inflammation in the ear, it leads to increased blood supply, vascularization, which then causes excessive shedding of the skin. So the skin dies and it sheds. So again, the theme of keratosis obturans is excess dead skin that can't escape the ear. And it can also, as I mentioned earlier, affect the migration route of the skin. Instead of moving sideways out of the ear, it sheds inwards, so it doesn't actually come out the ear, it just forms into a plug centrally. The other type is a silent type of keratosis obturans. So with the silent type, it's more of a chronic form, and this is what this patient's got. They're going to need regular cleaning. Whereas if it's due to inflammation, it can be a singular episode. For whatever reason, they've got inflammation of the ear canal. It can be caused by even scratching your ear with a cotton bud, for example. Leads to inflammation. That inflammation then leads to excessive shedding of dead skin. That skin fails to shed properly because of the amount, forms into a plug. So once you've resolved the underlying inflammatory reason, it's possible, if there's no significant widening of the ear canal, that it can be a singular episode. But in this case, it's probably more of a chronic form, so we call it a silent keratosis obturans. And the reason why this is going to be a chronic form is this patient's already got a widening of the ear canal. So when you've got a widening of the ear canal like this, it just makes it even more difficult for the ear to cleanse itself and shed itself of the dead skin. So it's just more and more likely they're going to get an accumulation of dead skin. So you can see some skin here. I'm just going to peel this away. So the treatments of keratosis obturans is regular oral toilet. So oral toilet is just the medical term for debridement of the ear. If your keratosis obturans is caused by excessive inflammation, so anti-inflammatory drops, so steroids, for example, and there is possible surgery. So surgery can include skin grafting to reduce the widenings of the ear canal, or the opposite. When you've got a widening of the ear canal already, you might want to widen other narrower portions of the ear canal to match the widening, so it's more symmetrical. The problem here is that when you've got some widening of the ear canal, medially and laterally you don't have widenings, then it creates almost like a well or pothole in the ear canal, so the skin can't naturally escape. When you've got general widening of the whole entire ear canal, hopefully that can facilitate the natural migration of the skin. See, this next skin layer is already developing on the canal wall, so I'm going to peel this away. And in a moment, you're going to see the posterior canal wall where the canal is beginning to widen and infringe upon the mastoid bone. When that occurs, it's the same with a canal wall down mastoidectomy, so someone with a radical mastoidectomy. The balance organ is, you've got these 3 semicircular canals, rings, or semi-rings, and one of them, the horizontal canal, or the lateral canal, it's based at the entrance of the mastoid bone. So if you go through the eardrum and turn left again, that horizontal canal is present there. So if we were to, you can see on the left hand side, so on screen at 9 o'clock, you can see the bone is widening into the mastoid bone. If you were to drill away all of that bone in that direct plane, you will then eventually see the lateral, or also known as the horizontal semicircular canal. And then when you perform microsuction, it changes in pressure and temperature can affect your balance organ. So quite often when patients attend with canal wall down mastoidectomy, or maybe in this case as well, where it's an automastoidectomy due to the keratosis obturans, they can experience a bit of vertigo. And the patient didn't experience them themselves. Again, with Keratosis Obturans, you normally do get this global widening of the ear canal. So it's not just one point in the ear canal, it's generally all the way around. You might get more widening in one part than others, but it's a widening of the bony part of the ear canal as opposed to an erosion like a canal cholesteatoma or benign osteonecrosis. So it's actually a physical widening. Well, I hope you've enjoyed that video, guys. Do take care, keep well, and speak soon. Bye.